Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm pleased to have today with me Dr. Paul Finger, who is a world authority on the management of ocular tumors. He's clinical professor at the New York University School of Medicine, directs the ocular tumor service at New York Eye and Ear Infirmary, and is chairman of the Eye Cancer Foundation. So done lots of great things. Also has been involved as a CEO of a startup, Liberty Vision, which is involved in some innovative therapeutic development. So welcome to Retina Synthesis, Paul.
Thank you so much, and thank you for inviting me, Carl.
Well, the focus of our series is typically on new developments in medical retina, treatment of age-related macular degeneration, diabetic retinopathy, but there's lots going on with the management of choroidal melanoma. Can you tell us today what the leading developments are in the management of choroidal melanoma? Well,
from the start, the biggest thing that's probably happened in choroidal melanoma is staging. The American Joint Committee on Cancer, which I'm the chairman of the Ophthalmic Oncology Task Force, has introduced through a 60-person multi-center international effort a standardized method of staging ocular tumors, specifically choroidal melanoma, which is very exciting because some work done by Tero Cavella showed that tumor width and tumor height could be used to prognosticate the risk for metastatic death. And that was seconded by two other studies, including one that I put together as another international multi-center effort. And so with the results of 19,000 patients, which is almost more than twice what was used to validate the AJCC for skin melanoma, we know that those size criteria are pretty accurate for diagnosing metastatic disease. You know, that's on the diagnostic side. But also on the diagnostic side, there's a lot of stuff going on right now with tumor biopsies. I'm sure that with the retina vitreous audience that everyone's heard of or seen tumor biopsies being performed. A ton of genetic information has been garnered from those biopsies. Unfortunately, treatments have not been married to the genetic information like we see, say, with breast cancer. The melanomas are a little tougher. There is a new drug that's sort of genetically driven, but those normal things that we look for are mostly prognostic indicators, and they will, because I'm still chair of the committee and Dr. Tero Cavella is interested in putting together a group, want to put together those size criteria together with the genetic criteria to make the prognostic staging system even better.
So what is the management of a newly diagnosed choroidal melanoma patient?
Yeah, it's interesting. You know, the COMS study, which goes back a bit, found that there was no survival advantage to removing the eye. And since that time, the indications for treatment have gotten wider and wider. And now basically almost everyone gets irradiated, either with plaque or a proton beam. So most patients are treated. The problem we have in diagnosis is like for medium and large tumors, it's easy, but for small tumors, it's more difficult. And so I actually developed a mnemonic called MOST, M-O-S-T, where melanoma equals orange pigment, subretinal fluid, and thickness of 2 or more millimeters. And for those retina vitreous people who are looking at a suspicious nevus, look for those 3, because if all 3 are present, most likely that's a melanoma. As far as therapeutic changes, we're still with plaques and protons. Not a lot new has come up in the last 5 or 10 years. We're getting a little more sophisticated in how we make these devices. The American Brachytherapy Society, which asked me to chair an initiative, another multi-center international initiative, suggested that everybody compare the radiation dose within the eye before they actually treat the patient. So a lot of centers now are comparing palladium versus iodine versus ruthenium plaques, and to see what structures are being radiated and how much, so that we can figure out what which radiation is going to allow for the best long-term vision preservation. So that's new. That's newer.
What are the indications for tumor biopsy?
Indication, well, it's interesting. Again, like the CMS study found that 99.6% of the time, a eye cancer specialist can tell whether it's a melanoma or not. So the old indications that were immortalized by Jim Augsburger was atypical tumor, metastatic tumor with an unknown primary, and when the patient wanted to have a pathologic diagnosis. And of course, that's changed a lot, and people are doing a lot of biopsies now. They are getting genetic information, but right now there's really little therapeutic advantage. Some centers are actually using the genetics. So if you have a bad GEP or BAP1 or monosomy 3, then they might see patients more often or scan their livers more often. But we have to be careful with that because there's other factors besides size and genetics that play a role in patients developing metastatic disease, like age, for instance. Younger people tend to get less metastatic disease than older people.
So molecular diagnostics in terms of prognostic situation, that there's been a ton of talk about that in the last decade. Do you do that?
I offer it to everyone. I've developed a couple of new techniques for biopsying intraocular tumors over the years, and so I have no problem doing it, but I don't like to do anything that doesn't offer the patient some advantage. And as you know, anytime we enter the eye, we do have risk of infection, hemorrhage, retinal detachment. Plaques, which I primarily use for treatment, are all extraocular procedures, so the eye is not invaded, and that offers me the chance to deliver on visual acuity and local control. Think about it, if the tumor hemorrhages and you, for some reason, have trouble localizing the plaque with ultrasound and you want to do ophthalmoscopy with scleral depression, it's going to be a lot harder if the patient has a vitreous hemorrhage on top of their choroidal melanoma. So I try to do everything I can to maximize local control, and that's probably one of the reasons why my local control rates now are 99.7%.
Are patients interested in knowing their prognosis from a molecular basis?
Yeah, and I think that you can tell them their prognosis based on tumor size also, which is non-invasive. But think about it also, if you have, let's say you have a bad molecular prognosis and you have comorbidities like heart disease or some other cancer, and a lot of these folks have multiple cancers. Do you really want to have that black cloud sort of hanging over people? And there's been some patient-reported outcome studies that show that patients do carry worry along with them. So I'm not sure that there's, I think you need to offer it to people and explain these things to people, but I don't routinely perform tumor biopsies.
No, I think that sounds sensible in terms of practical management. What's new on metastatic disease? Anything?
Yeah, there's a new drug. The drugs are so hard to pronounce these days. I wrote it down. I send all my patients to Anna Pavlik at Cornell. She's just a wonderful medical oncologist. She co-wrote the chapter in DeVita's cancer with me. And there's a new drug called Tebentafusp, Tebentafusp. And it is a molecule. It's not one of those things that's directly related to BAP1 or GNAC or monosomy 3, but it does appear to be very hopeful in diminishing the rate of growth of metastatic lesions. As you know, there's really no great immunotherapy. I can tell you from my experience with Dr. Pavlik is that an artful medical oncologist can keep folks alive by find early detection and treating their livers and other sites of metastatic disease before a fulminant event But right now we don't have a cure, unfortunately.
So can you talk a little bit about your work as an entrepreneur in the medical device space?
Yeah, for sure. So, it's interesting. I got into building a company 9 years ago. And it was because I had patented a device originally for treatment of the macula with lights. I had done some work with eye plaques, putting diode lights on them, and that was all published. And what would happen is the edges of the plaque had lights, so you sew it in and then you plug it in. And then you look inside the eye through the pupil and you see 4 lights around the tumor. And you know exactly where the plaque is. And anyone who puts in plaques knows that it's nice to get that much reassurance. It's almost impossible otherwise. But as putting on my business hat, and I do have to wear a lot of hats these days, I realized that first it's electronic. So to get something through the FDA that's electronic, and there must be a better way. And I actually had a industrial designer come to me and show me how this could be done with fiber optics. So once we got rid of the electronics, we developed a fiber optic handheld applicator that could hold a radioactive source in place on the back of the eye, and where you could look through the pupil and see the lights and know exactly where the radiation source was between the lights. And that was pretty remarkable because, we all come in we drive, fly airplanes or passengers in airplanes, and we come into at night and we come in on the runway, and there's a row of lights on either side of the runway, and we know that it's a leap of faith that there's going to be a runway between those lights, right? And so we know when we look through that pupil that there is a radiation source symmetrically between those lights, and we can tell exactly where we're radiating. The other thing I learned about being an entrepreneur is that most entrepreneurs actually in their 50s and 60s, because they sort of been through the industry for a while and they know what the industry could really use. And this was also played a factor because I knew that I wanted a radiation source that was high dose rate, which means that it's not going to be dwelling there for a week. And I wanted something that only went into the eye a few millimeters, because why would I want to radiate anything other than what I was trying to radiate? And so that was the basic principles behind the design of the Liberty Vision devices. We have a source which will be in multiple sizes, and we have 2 handheld applicators, one for the front of the eye and one for the back of the eye. And I invite you all to go to libertyvision.com and take a look. They're pretty nice. They're translucent and very ergonomical. They weigh less than a pen, and so it's really easy to handle them and place them.
So what are the clinical indications for their use?
FDA has approved it for ocular tumors and benign growths.
So how would you imagine using it in a real world setting?
Yeah, so that's up to interpretation of the physician. I'm definitely plan to use it for ocular tumors and uveal melanoma, very small uveal melanomas.
Mm-hmm.
I hope one day we have much larger devices for larger melanomas, and we can even change the radiation source, sort of custom make it to different depths that need to be reached as we go along.
What's the radiation source now?
It's yttrium-90. So yttrium-90 is an interesting source because the old strontium-90 was really strontium-yttrium. It was in secular equilibrium, which means that the strontium was giving off yttrium, and that was really the therapeutic part. The strontium didn't go very far, the yttrium did go about 4 millimeters. And so when we were doing those old pterygiums and things like that with the old strontium applicator, not too many people even remember them, but it was like a steel rod. Mm-hmm. with a round flat disc on the end where you put on the eye, and it was sort of bulky and heavy and difficult to hold, and it did the job. And there's a lot of clinical work on using that device. This device is got rid of all that. It made it something that was lighter than a pen, and could be placed just about anywhere. And you didn't have to worry about a lot of the heaviness of it, because these treatments often take 5 to 15 minutes. So imagine trying to hold something that's really heavy for 5 to 15 minutes. It wouldn't be practical for the surgeon. So, I basically used my experience of being a physician since the mid 80s to say, if I was going to design something to make it as easy to use and for many things, many ocular tumors and benign growths, how would I do it? And that's what we came up with the Liberty Vision devices.
That's very exciting. So how much time do you devote to the Liberty Vision, and how do you balance that's demands with your very busy clinical and research practice?
Well, I don't know. I get things done. Perhaps I don't spend as much time as I should not working, but I did condense my practice a bit, and I do spend Mondays, Fridays, and lots of the weekends doing Liberty Vision. I have some wonderful people working for me. I was very, very lucky to find very talented engineers and clerical people and support staff, scientific people. And because of my experience being, I was asked to be in the TG 149, which you probably don't know what it is. It's American Association for Physicists in Medicine, had a task group to figure out how to do medical physics for eye plaques. And I was the only ophthalmologist, definitely, and probably, I think I might have been the only physician that would be invited to that. And I learned, and more than that, I met a lot of really, really smart people. And so what did I do with this business? I reached out to those smart people, and I made, like Dr. Mark Rivard, who's a brilliant medical physicist, and I brought him into the scientific board, and Wolfgang Sauerwein, who is a leading or the top ophthalmic radiation oncologist in Europe, and brought them all in. I said, the more experience that we can get together, the better the device will be. So it's really been a wonderful educational experience, and just learning to be CEO too is something. I'm in private practice, so I've been CEO of the New York Eye Cancer Center, but it's not the same. You have all kinds of other issues that come up with the company.
What do you think the biggest research initiatives should be in the management of ocular tumors?
Right now, I think the most important thing we can do, there's two things really, and one of them we're doing. The Eye Cancer Foundation is reaching out around the world to train ophthalmologists to go back to their unserved or underserved country to treat retinoblastoma. About 60 to 70% of patients with retinoblastoma around the world die, and less than 1% in the United States. And the difference is there are people who know how to treat them here, and there's treatments here. And so when I learned that, I decided to focus the foundation on training people to go back to their countries. And we've trained over 50 people so far. I realize it's just the beginning. They have to be equipped. But we're working on it, and I'm hoping that is something that it just keeps going. We're planting seeds, and hopefully they'll grow into a forest. The second thing, which is really important, and it's already happening in retina, but really needs to happen in ocular oncology too, is machine learning. And that is, we need to be able to feed thousands of images, what I call educated images that come with a description, and develop machines that can help us diagnose tumors. I think it's a reasonable goal. It's quite difficult goal. I think it may be, I'm not sure, maybe easier with other diseases because there's less variety in some of the other diseases, but I think it's something that should be done. And I would also be interested if a group wanted to get together to raise money and make that happen.
Well, Paul, this has been a wonderful discussion about your experiences and your vision for the future. And congratulations on the great work that you've been doing, and fantastic outreach. Thanks for joining us on Retinal Synthesis.
Thank you, Carmen. It's a pleasure to see you again.